Some of the named gait signs that we want to talk about include those named gait signs that are described in the AMA guides, such as the antalgic gait and the Trendelenburg Gait. And we also want to talk about some of the other types of gaits that we will encounter in the qualified medical evaluation, but that are not specifically described by name in the AMA guides. So some examples include the broad-based gait, and I'll give you several different types of examples of that. The steppage gait, the Gluteus Maximus Lurch, and then also to illustrate a principle that we commonly encounter in the qualified medical evaluation, I want to talk about the festinating gait. And that's an example that's going to illustrate the principle that during the qualified medical evaluation, we may encounter other comorbid conditions that overlie and overlap the industrial injury. And I'm going to cite an example wherein I identified an examinee who had the development of Parkinson's syndrome over and above and on top of his industrial injury, and it was the qualified medical evaluation that was successful in diagnosing this condition for the first time and in directing the examinee toward medical treatment for this condition. Even though the medical treatment was non-industrial, it was the QME evaluation that identified the condition, and it was identified through the presence of what appeared to be a festinating gait. Okay, so let's begin with antalgic gait and talk about each of these named gait signs. And I have a real treat for you here, because in addition to our descriptions of these gait disturbances, I also have some videotaping for you at the conclusion of this section that demonstrates each of these gait disturbances.
Okay, so let's begin with the antalgic gait. Now, an antalgic gait is a gait that's characterized by leaning away from pain. In fact, the word antalgia comes from the Greek word anti-algos, which means simply away from pain. So with an antalgic gait, we see that the examinee leans away from pain. So what would be some examples of that? For example, in the case of a right-sided lower back pain, an examinee with right-sided lower back pain, they'll be observed to lean where? They lean to the left. They lean to the left in order to get away from the pain, which is on the right. And you've probably seen examples of this before. Let me ask you, Mr. Attorney, have you ever seen a person walking seemingly crooked? It looks as though their torso is crooked. Sometimes someone will walk towards you and they look like a comma, meaning that they're leaning and their torso is curved one way, or they're walking crooked, whether it be bent forward or leaning left or leaning right. These are all examples of antalgia. And this person might think you're a genius if you were to come up to them and try to identify their problem, because in most cases you can correctly identify the problem by seeing where they're leaning. They're leaning away from the pain. The pain is on the opposite side. Okay? So as another example, in the case of a person with an ankle sprain, sprain of the lateral talofibular ligaments, that is, they would be observed to shorten the stance phase on that leg in order to get away from the pain. And we would call that a limp. You say that the person is limping. Well, this is an example of an antalgic gait. And the interesting thing about antalgic gait is that the level of the pain determines the degree of the antalgia, or the shortening of the stance phase that you will observe. And I have a video of antalgic gait coming for you shortly. The next gait is the broad-based or so-called ataxic gait. This is found in a variety of different types of conditions, including traumatic disorders that we see in the workers' compensation setting. And this is due to an impairment of the ability to coordinate the movements required for normal walking. And this can be due to impairments of either motor function or sensory function. And this is commonly seen in the cervical myelopathy cases under Chapter 15, those examinees with a spinal cord injury. They have impairments of both sensory and motor function. So imagine a person who, for example, has numb feet due to either central nervous system disorders such as cervical myelopathy, or even a peripheral nervous system disorder such as diabetic neuropathy. A person who has numb feet has impaired sensory feedback from the feet. Therefore, they have difficulty with balance, and therefore they have a need to widen the base of support. And I gave an example earlier of getting up in the middle of the night and trying to get down to the bathroom without bumping into walls on both sides of you. And I have a video of the broad base gait coming up for you shortly. The Trendelenburg Gait is specifically described in the AMA guides. And the Trendelenburg Gait was first described in the 19th century by orthopedic surgeon Friedrich Trendelenburg. He identified this particular type of gait in children with congenital dislocation of the hip. And I have two examples of Trendelenburg Gait coming up for you. One is my own interpretation or my own imitation of Trendelenburg Gait. And then also I have a live examinee who beautifully demonstrates the Trendelenburg Gait due to congenital hip dysplasia. Now, the Trendelenburg Gait, regardless of its cause, whether that be in juvenile or adult examinees, in our case in workers' comp we're talking about adult examinees, but regardless of the cause, a common feature of all examinees is that they present with weakness of the gluteus medius muscle. So this would be accompanied by positive and true objective physical examination findings, such as weakness of the gluteus medius muscle, which is one of the gluteal buttocks muscles. Now, the gluteus medius muscle is responsible for stabilizing the pelvis as the legs go through the gait cycle. So a Trendelenburg Gait manifests itself by a sudden dropping of the pelvis inferior, in other words, a downward dropping of the pelvis on the non-weight-bearing leg. So as the weight-bearing leg goes through the stance phase of gait, the pelvis on the non-weight-bearing side drops inferior, drops downward due to lack of stabilization of the gluteus medius muscle on the side of the leg in stance phase. And this is a pronounced deviation in gait, and you will notice it. And I have a video for you coming up to demonstrate the Trendelenburg Gait. Now, because of weakness of the gluteus medius muscle and a dropping of the pelvis on the non-weight-bearing side, the examinee has to compensate for this. Otherwise, they would fall over towards the non-weight-bearing side. So in order to prevent themselves from falling over, they throw their body toward the side of the leg going through stance phase. And it's a quite pronounced and awkward gait. In fact, when I was videotaping my demonstrations for you, I found it quite exhausting to do 3 passes of the Trendelenburg Gait. And I'll show you that here coming up shortly. The next gait to go over with you is the steppage gait. This is also known as the equine gait, and you've seen these types of people out in the public before. It's quite a pronounced deviation in gait, and it's quite common actually. And the interesting thing about steppage gait, well, first of all, steppage gait is due to loss of use or loss of function due to weakness of the front shin muscle, known as the anterior tibialis muscle. And the anterior tibialis muscle is responsible for lifting the ankle into what's called dorsiflexion. Now, this can be due to a direct trauma to the anterior tibialis muscle, such as a contusion, or can be due to a neurologic disorder of the spinal nerves, typically L5, or due to injury of the common peroneal nerve. And I don't know if you've ever had an injury to the common peroneal nerve, but I have. And the common peroneal nerve is interesting because, like the ulnar nerve in the arm, the so-called funny bone nerve in the arm, the funny bone nerve is very superficial and easily struck by bumping your elbow on objects. Well, the common peroneal nerve is very superficial as it comes around the outside of the leg just below the knee where the top of the fibula bone is. The nerve is very superficial there. And one day I struck that nerve on a bench in the gym locker room, and all of a sudden my anterior tibialis muscle went limp, and I could not control my ankle for like 15 minutes until it slowly started to come back. Well, people with steppage gait have varying degrees of disguise for the disturbance. Someone who's had steppage gait for a long period of time learns ways to circumduct their leg and learns ways to subtly and almost imperceptibly lift the hip and the knee to disguise the dysfunction at the ankle. But if you're sharp and if you're astute, you can pick it up. Because due to inability to control the ankle, there's increased hip and knee flexion in order to bring the foot high enough for the toes to clear the ground. And like I said, this can either be subtle or it can be profound. And the videotape where I demonstrate this coming up in just a minute shows the example of the more profound steppage gait. The next gait is the festinating gait. This is found in central nervous system disorders such as Parkinson's disease, all of which are characterized by near spasticity, or what's referred to as hypertonicity, overtone of the lower extremity muscles. And with a festinating gait, the examinee has difficulty in getting the gait initiated due to difficulty in moving and difficulty in coordinating the lower extremities. But once the gait gets initiated, the steps become increasingly shortened, almost as if stumbling and almost as if running by falling forward. And it appears that the examinee is falling forward, unable for the legs to catch up with the body. And a similar example of festinating gait is sometimes seen in toddlers who are just learning to walk. You know, they will take one hesitating step and then take another hesitating step and then another and another and another, and they all of a sudden they're almost running, and then they come to a quick stop as they catch their balance and get their wits and get their legs back under them again, and then the cycle repeats, and this is the same type of a gait that we see with the festinating gait. Then finally, the gluteus maximus lurch is an interesting gait disturbance. It's not as frequently seen as the Trendelenburg gait or the steppage gait, but it is out there because it is also caused by injury to any of the spinal nerve roots, L5, S1, or S2, or also due to an injury to a local peripheral nerve known as the inferior gluteal nerve, which can often be damaged with hip replacement surgery. So injury to the inferior gluteal nerve or any of those nerve roots causes a weakness of the gluteus maximus muscle, and you're all familiar with the gluteus maximus muscle. So with weakness of the gluteus maximus muscle, we have inability for the hip to extend. The gluteus maximus is a hip extensor muscle. So lack of normal hip extension strength of the gluteus maximus requires compensatory extension of the torso over the hip. Otherwise, the examinee would simply double over and fall forward at the hip during the heel strike phase of gait due to lack of stabilization through the gluteus maximus muscle. And I have a demonstration for you here. Now what's interesting is if we think about the Trendelenburg gait and we compare it with the gluteus maximus lurch, both of them include compensatory movements of the torso over the base of support, and the base of support is the hip socket. But the Trendelenburg involves a lateral or sidewards compensation, whereas the gluteus maximus lurch is characterized by a posterior or backwards compensation. So the Trendelenburg gait is very well demonstrated and very well visualized when viewing the examinee from either the front or the back, whereas the gluteus maximus lurch is very well demonstrated and best visualized when viewing the examinee from the side. And this illustrates the principle of the necessity of observing the examinee from multiple directions. Okay, and so I'll show you a videotape of each of those gait disturbances in just a moment. There are other types of named gait signs that are more esoteric and not as commonly seen, but that you may run across, including the athetotic gait, the Charcot's gait, frontal gait, hysteric gait, and dystrophic gait. Probably the most common of which that we would see in the workers' compensation setting would be the Charcot's gait, which is due to progressive and chronic joint damage in the lower extremities, such as in the toes and in the foot. Okay, so those are some of the named gait signs. Let me now show you a videotape of demonstrations of these named gait signs, and this is me demonstrating these various gait disturbances to the best of my ability. Much more unpracticed at it than a person who has lived for a long period of time with a gait disturbance. But anyway, you will get the idea. So for those of you that have the PowerPoint presentation, here is your link. And for those of you that have the handout materials, I've included a quick response code for you on your handout materials. And so I look forward to being back with you after you review this brief video.